On behalf of the Chronic Liver Disease Foundation, thank you to Intercept Pharmaceuticals for their support of this podcast.
Welcome back to the GHAPP CLDF PBC podcast series. My name is Andrea Gossard, and I'm your host for today. Thank you for joining us for the 8th and final episode of this series. For those who haven't, please feel free to go back and view the prior podcasts for greater information on PBC. Join us today as we dive one last time deep into the intricacies of primary biliary cholangitis. In today's episode, we will explore the importance of a holistic approach when managing primary biliary cholangitis, focusing on comprehensive care that addresses both liver health as well as comorbid conditions and overall well-being. This will include lifestyle modifications that our PBC patients can consider, as well as the potential benefits of integrative medicine. Joining me today is a familiar face. Christina Hanson, a family nurse practitioner and expert in PBC, as well as a fellow GHAPP board member, is joining us for our episode. You may remember Christina from our episode 1, and she's back here for our final episode on PBC. Welcome, Christina.
Thanks for having me, Andrea. It's great to be back.
It's great to have you back. Okay, let's get started. So when we think about comprehensive care of the patient with primary biliary cholangitis, my goodness, we oftentimes think of, what are the different ways that we can impact their quality of life and sense of well-being outside of just our treatment algorithms. Tell me a little bit about what you focus on when you meet with a newly diagnosed patient with PBC.
Yeah, so I think it's important to have a really good discussion and educating moment with our patients with PBC that really talks, about the liver and the potential damage in the liver and the kind of natural pathophysiology of the disease when it comes to the liver, but also that there are many extrahepatic manifestations of PBC as well. That can be other conditions, but also symptoms. And by the time a patient with PBC finally rounds out a diagnosis, they have a tendency to kind of live with their own norm. And, we all are a little tired once in a while, but, the fatigue for patients with PBC can be very debilitating. And sometimes it can be mild and it can fluctuate. I'm in Colorado. Sometimes we have dry winters. There can be a little bit of natural itch just around dry skin. But, is there more of a pruritus or an itch for this patient that's suggestive of secondary to the actual disease of PBC? So having those discussions around these potential extrahepatic manifestations and wanting to get a baseline assessment for those. So we know that patients with PBC can be more prone to having issues with bone disease. So if they don't have an updated DEXA scan, I certainly will pull one. I'll order one for that patient. I don't tend to manage bone loss or osteopenia or porosis, so I will send them back to their primary care or possibly endocrinology. But I think that's important to get that baseline, especially because there are individuals that don't really have an established primary care. So I will even still put a little tickler in if it's a 2-year recall to repeat that DEXA scan just so somebody's watching that patient. We know that patients with PBC can have dyslipidemia. You don't look at the patient population. They don't look like they necessarily should have issues with high cholesterol, but with this cholestatic disease, this is a phenomenon that can happen. And this really is exhibited by an elevation in total cholesterol, primarily from that elevation in HDL. So we want to make sure we're checking a baseline lipid panel and periodically for monitoring that for that patient. And then it comes down to if we do have dyslipidemia, I think you take into account the degree of elevation, their risk factors, their age, which again, tends to be middle age and women, but age and gender. And if they do have significant additional cardiovascular risk factors, then may be an indication for a therapy, statin therapy or dyslipidemia therapy. But we recognize this patient population don't tend to have those additional cardiovascular risk factors. And in fact, there are studies that suggest that there really is no increased risk for cardiovascular disease in patients with PBC and these high cholesterol. So again, I think that's taking it case by case. But we talked about this earlier on in the series. Is we do tend to see a supersized world, so it's not uncommon for these patients to come in with additional metabolic conditions, including fatty liver. And as a hepatology specialist, I think sometimes we'd like to pour statins in the water. We know the benefit of that. So sometimes I'll manage that, or sometimes I will have the primary care take that. And then there's the increased risk of having deficiencies in fat-soluble vitamins. And so I think that, again, that's important to get that baseline. And it's frequently deficient in these patient populations. So that is something that I will go ahead and prescribe and supplement myself. So I usually will manage that for these patients. So again, looking through first those extrahepatic manifestations and getting all those baselines on these patients. And I know we'll talk a little bit more about, the symptoms that these patients exhibit and what we can do for that.
Yeah. Thank you. So I'm curious, when you have patients who have an elevated lipid profile and perhaps they do have some cardiovascular risks that are concerning you, what is your your evidence or what do you recommend to patients who are wondering whether or not you are okay with them using a statin in the setting of newly diagnosed or previously diagnosed primary biliary cholangitis?
Yeah, and I think this is really important too to have a kind of dispel the myth around statins, and document that in your notes so that their primary care can see that
Yes.
you're, and we've actually had a discussion around this before with colleagues that even though we don't tend to manage dyslipidemia and manage the statins, I find myself doing it a little bit more often, at least initiating it. Uh, Almost to show primary care that I, as the hepatology specialist, am comfortable with it.
Yes. Yeah.
And we're comfortable with statins. So sometimes, there's just still such a hesitation in this misconception that statins, cause actual, liver damage. There can be some transient elevation with statins, but really not infer any kind of injury to the liver. So the actual incidence of DILI related to statins, I mean, it's really negligible. So having those conversations, dispelling those myths, not just for the patient, but also documenting it or having conversations with their primary care around it. So, yes, if they do have cardiovascular risk factors, and I would want to make sure if this patient hasn't had a cardiac evaluation, been established because they have other comorbidities, certainly I want to bring in, the multidisciplinary approach and bring in the cardiologist to make sure they have a baseline cardiac evaluation as well.
Sometimes if there's a patient with angst about starting the cholesterol medicine, whether it be a statin or something else, I will offer to have follow-up liver tests after 2 and 4 weeks of use just to ensure that they remain stable, because I think that sometimes is just reassuring to the patient and then they're a bit more comfortable with proceeding.
Absolutely.
But I agree with you completely that dispelling the myths is absolutely essential.
Mm-hmm.
Let's turn now a little bit to symptoms associated with PBC. So when I think about a new consult coming in, oftentimes questions are really related to how can I manage this fatigue or how can I manage the pruritus if that's a dominant issue for them. Again, some patients have no pruritus whatsoever, but maybe up to a third or so, that's one of the main symptoms they're wanting to talk about. Walk me through how you manage kind of those key issues when patients are concerned about them.
Yeah. And again, having that conversation, I think it's really important for providers to be assessing at baseline and at every visit. And again, we have this idea that these patients are fairly asymptomatic, fairly responsive, even just to first line or so. But if they don't know what to be looking for, and there's periods where they do have itch and days where it's better, and same with the fatigue, it could be slowly progressive. They may not know to bring it up. So having, again, that good conversation initially and having them make sure that they monitor that. And then, yes, I mean, fatigue, it tends to be one of the most common. Pruritus and fatigue kind of neck and neck. And for some patients, both symptoms can be debilitating. We know that there's even some transplant exception around, refractory pruritus that's not unresponsive to treatment. But breaking it down, fatigue, certainly, there's not really a lot of great pharmacologic management options for these patients. We recognize that fatigue, as well as pruritus, even with improvement in response to with second line therapy, even disease response does not resolve these symptoms. So that can be disappointing for our patients, but I think that's also important to talk about and kind of level set that expectation. But as far as fatigue, I think there's non-pharmacologic things that we can encourage our patients. Having good sleep hygiene, making sure that they stay well hydrated, that they have a degree of physical activity per what they can manage, because exercise can be a benefit, can be helpful. We know that with fat-soluble vitamin deficiencies, and notably vitamin D, which if you ask me, I feel like everybody's
Yeah.
got vitamin D deficiency out there, PBC or not. It
Right.
just everybody's got it, men and women.
Yeah.
But replacing, there is some data behind vitamin D replacement can actually be somewhat improve fatigue. And I think for those patients that are really severe, making sure we're not missing something else that might be contributing to the fatigue. But so those are some of the things we talk about. It's the things you talk about with your kids, or just you and me out there in the world. It's not beyond the screens. Before we go to bed, so have some kind of good kind of steady practice that you do every night, and trying to kind of shut that brain down and shut your mind down. I think can be helpful.
Yeah, absolutely. That's what I always tell patients when they ask, and understandably very frustrated by the fatigue they experience. But I explain that it's really everything that you'd recommend to anyone with or without a liver disease, with respect to regular exercise, healthy diet, healthy weight, restorative sleep, stress management patterns. All of those kinds of things are really the only tools that we have at our disposal. Unfortunately, there haven't been any great breakthrough therapies for the fatigue associated with cholestatic liver disease or liver disease in general. When you think about pruritus management, kind of what is your standard approach to that patient who's either coming in with pruritus or newly pruritic now, well into the disease? Because we know that the pruritus doesn't necessarily correlate perfectly with the stage of disease. So how do you typically, what's your first line therapy?
Yeah. So I think, and patients really buy into this too. They want to know if there's things that they can be doing to help that aren't necessarily, medication. And, patients who have, severe pruritus, they'll take anything,
Yeah.
medication as well. But I think those non-pharmacologic options, and again, going back to the good sleep hygiene, because a lot of times this is can be very bad at night, for our patients. So that this nocturnal pruritus. So again, having those good sleep hygiene practices in place, white noise, clipping their nails, trying to avoid, because you've seen them, they're sitting in front of you and they don't even realize, and they're just scratching in front of you at their office visits, and they don't even realize that they have excoriations, that you're seeing on their back. They're grabbing the spaghetti spoon out of the drawer, and they're going at it at home. So trying to have short nails so they're not making excoriations on that. Again, staying well hydrated. So diet is often something that I ask about, and unfortunately, we don't espouse to one diet being better than another, or that it would change the disease itself. But like you had mentioned, making sure healthy diet, especially if there's some coexisting fatty liver, other comorbidities. I think women tend to not be as good with their protein either. So when I look at fatigue and just energy and such, I try to make sure that they're getting a good amount of healthy proteins in daily as well. And then, smoking cessation is very important as well. I mean, it's just good for, obviously global health, but it can be beneficial for pruritus in this patient population. And then we'd look into the pharmacologic measures, and I would say that I would tend to go for a bile acid sequestrant first. Obviously, counseling around taking it, because it can bind up all the other medications, and that can be kind of tricky with URSO, which sometimes, based on weight-based dosing, can require divided doses as well. So it can be a little tricky managing that bile acid resin, but that's usually my first line. And patients will ask about this too. What about some kind of antihistamine or Benadryl or something at bedtime? But the problem is these patients also tend to have Sicca-like syndrome and dry mouth. So then that obviously can be exacerbating for them. So it is an option depending on that patient and what else they're experiencing. Actually, someone the other day, a KOL, APP expert in PBC, brought up primrose oil in an encapsulated form that actually her patients swear by. So that was something new for me, but something kind of anecdotal and over the counter. But yep, definitely a bile acid resin. And then we definitely have other options: naltrexone, rifampin, even SSRIs have, some studies have shown benefit there.
Yeah. Patients don't tend to like the cholestyramine. We know that it's not a very pleasant thing to take, but in my experience, it still is a great first-line approach to pruritus. And I think, thankfully for many people, it can make a difference. But as you say, not for all. And then you need to think about escalation of therapy, as you'd mentioned. So when you think about, we talked a little bit about lifestyle and how that might benefit their disease course as well as symptom management. I think nearly every new consult I see will ask me, what can I do? Which I understand. We all want to try to make a difference with respect to any conditions that we're diagnosed with. If you had to counsel people on healthy lifestyle, what would that include? I know you've alluded to it a little bit, but do you get into even more detail with your patients?
Yeah, I think it kind of goes back to just kind of general healthy diet. We are so inundated right now with MASH that I feel like my go-to is always low carb. But they come in and talk about Mediterranean, or they talk about inflammatory or anti-inflammatory diets. And again, really, we know that there's just not one that's just going to be better than another when it comes to PBC. But just really kind of looking at getting your good squares, making sure getting those food groups in. I tend to like low carbohydrate in general. And then, if there's some ability to utilize a dietitian, just again for overall nutritional counseling, I think that brings in that multidisciplinary approach as well. And again, for women, the tendency to just not be really good with your protein. So I think there's an option of bringing in a dietitian just for just nutritional counseling. We know the benefits of exercise, regular exercise. And again, it's going to be finding something that that patient enjoys and something that fits their schedule. But I think that's really important as well for overall health, keeping the ideal body weight, and then helping with sleep as well. So that general dietary and lifestyle recommendations, and then there's options. We don't know a lot about complementary therapies. We will have patients ask about acupuncture, ask about yoga, some of these other complementary. And I think what I like to say is to each their own. If it feels like it's something that benefits, stress reduction through meditation or yoga, I think these are things that we can certainly encourage our patients to consider. Whether or not there's really great evidence behind it, it's certainly, as I talk to my patient, doesn't harm anything, in this aspect, to do some of those non-pharmacologic measures for lifestyle modifications. Yep.
Absolutely agree. I think shortly after the initial question of what can I do is oftentimes, it's often followed by questions about two main things. One, is alcohol okay? And number two, are there any, herbs or supplements or over-the-counter remedies that I could begin taking that are going to make a difference? Or sometimes it's, my cousin's wife said that this is what I should take. What are your recommendations regarding those other issues?
Great question, because the alcohol comes up no matter what underlying liver disease it is, right? Hepatitis, fatty liver, PBC. So we know that if you really wanted to, get into the minutia and split the atom, there's some studies that show someone who never drinks a drop of alcohol versus someone who has once a month versus someone who has once a week versus that person who, you can really get into the weeds there with even one a month versus someone that doesn't. There's longevity there. But if I have a patient who it really has no significant fibrosis, really there's not a lot of evidence that around PBC and concurrent alcohol use that say that it shouldn't be. We just don't have that data. So we have that discussion around in moderation and what that looks like for a woman versus what that looks like for a man, and really the kind of the guideline recommendations around that. Personally, when you look at this kind of overarching, hey, a woman can have a drink per day, 2 only when she's celebrating, and guess what? That's not every day. What's a drink? Well, 4 to 6 ounces of wine, 1.5 of hard liquor versus a 12-ounce. I don't necessarily want my patient drinking a drink every day even,
Right.
So I break that down even further. So really we look at, just kind of social limitations there, but it's not that you can't ever. Now, when I have a patient who is getting into stages of fibrosis that are more advanced, of F2 or greater, then I really start to kind of have that conversation of my preference would be having you not drink at all, given this more advanced stage of fibrosis. So that's when I really kind of put my foot down and say, this is going to be my hard, my hard line in the sand of recommending no alcohol use in that sense. And as far as other, kind of over-the-counter herbal, patients really do want those choices. I'm out in Colorado, close to Boulder. We're all brewing our own kombucha out there. We're all really interested in gut microbiome and, alternative medicine and things of that nature. So, and there's a lot of different things that are advertised for liver health, in general. I have many patients, again, PBC or different liver disease that come in on milk thistle. on some of these therapies. And there's some studies that suggest an anti-inflammatory or antioxidative benefit with milk thistle or curcumin or some of these other therapies. Unfortunately, we just don't have a lot of really good randomized controlled studies that show or prove their benefit. Whether or not they're harmful, we just don't have the evidence that show they're of benefit. So I just kind of say to my patient, hey, save your pennies. There just really isn't any evidence to support that as much as they really want that. And unfortunately, I do go into a further conversation around, unfortunately, I see way too many patients coming in with drug-induced liver injury these days from some of these things that are touted as liver health, ashwagandha and Asian knotweed, and some of these things that you've had several over the last handful of years that are using over-the-counter and herbal supplements that, unfortunately don't have an FDA approval or, kind of policed as to what's in it, and they're causing actual drug-induced liver injuries. So again, I think that helps them to understand the concern around that because, again, everything looks like it's supposed to be for the good of the liver, and in the end, it can be harmful.
Yeah, I agree. That's something I see way too commonly in the practice that I'm in, and I think that oftentimes it is just that closer monitoring, that advice that, really we want to avoid things that aren't well tested in this setting because we don't want to be causing those liver injuries. So thank you, Christina. These have been wonderful insights. We very much appreciate you being on this podcast once again and wrapping up our series on PBC. Thank you so much for joining us today.
Yeah, thanks for having me back. It's been a great series.